Hello everyone, my name is Dr. Raina Joshi and I have done my Masters in Dental Surgery in Conservative and Endodontics from Manubhai Patel Dental College, Vadodara. Today's topic that we will be discussing would be pulpitis and the inflammation within the pulp and how this inflammation induces the pain and how we can clinically diagnose it based upon the signs and symptoms. And so we may come up with the decision making in our clinical scenario and lead to a successful treatment outcome. So to know that, basically first we must know that what is pulp dentin complex, what is the pulpal vasculature, how the regulation of blood flow occurs, what is the neural innervation and how this neural innervation contributes to the inflammation and the pain symptoms, and what is the sequelae leading to pulpal inflammations, and how this sequelae leads to the pain, which leads to peripheral sensitization, central sensitization, and depending on that, what types of pulpal injury and types of pulpitis we have, and how we could clinically diagnose the patient, and how we would go for the clinical approach to this diagnosis. So coming up to the introduction part, as we know that pulpitis is equals to inflammation to the dental pulp. So pulp itself is a very complex organ, and it is richly innervated, highly vasculated. However, in spite of that, it has a good capacity of preserving its integrity to the pulp dentin complex. But it's always that the dental pulp is enclosed within a mineralized rigid space and it is inextensible, right? If we have a normal swelling on skin, we can get edema. But in such cases, it is already rigid, so there are no chances of edema in cases of pulpal inflammation. So this is the one aspect which leads to decreased pulpal resistance for its healing capacity. Next, we have that the source of blood supply is through the arteries that enter through a relatively very restricted apical opening, right? And the venules also exit through the same opening. So it's a very small area through which it enters and goes, and also it lacks the collateral circulation, which makes it difficult to survive during that times of inflammation. So the most important aspects we will consider that we consider it as a highly resistant organ, although which is encased within the enamel and pulp, but also it is considered as least resistance with least healing capacity when there is an increased pulpal inflammation. So the two most important components that are responsible for the pulpitis, they are the vascular component and they are the neural component. So the vascular component are the component which will lead to the stimulation of the neural component, and neural component in turn will give us the clinical signs and symptoms, or will respond or lead to some changes within the vascular component in some or the other aspects. So in this way, both vascular component in neural component individually play a role in the pulpal inflammation. However, they are intermingled with each other to produce the sign and symptoms clinically. So we must learn both the components and their contribution for the inflammation. Know that we first and foremost thing that we must know that is the pulp dentin complex. The pulp dentin complex basically consists of dentin odontoblastic process, pre-dentin, that is the cell-free zone, the cell-rich zones where the free nerve endings enter the odontoblastic process inside. So if we talk about the odontoblastic cells, they are the one of the most unique cells that we have in the dental pulp, and that the first line of the cell defense cells which the pulp will encounter. So when we are having caries, it will come to enamel, it will come to dentin. So in dentin we will have the odontoblastic cells which will the ones to receive the irritant, and when the noxious stimuli invades the dentinal tubules. So they are considered the first most antigen recognizing cells and to the bacteria and the toxins that are produced, or the pro-inflammatory cytokines that are produced. So also as they are the first recognizing cells and they are closely associated with the free nerve endings, the pulp sensory nerve endings that are present there. So they are considered to capable of modulating the neural activity via paracrine signaling. What is meant by paracrine signaling is the cell to cell response that is there, that one cell is receiving the response, it is recognizing, it is giving a response, it is transforming to the adjacent cell, and accordingly the response is being transmitted. So in this way, odontoblastic cells, they can modify the local pulpal microenvironment and also may contribute to the healing process in some other aspects. So once it is being recognized, so the next component that we have is pulpal vasculature. So we have pulp dental, it is richly supplied and vascularized, and we have the arterioles venules that are arranged axially in the pulp with the capillary loops extending out towards the dentine. The rich capillary plexus that we have in the subodontoblastic layers, which is well located for the transport of nutrients and oxygen, and they meet the functional and metabolic demands of the odontoblastic cells, as well as they also contribute in the repair process by angiogenesis, neoangiogenesis of the vessels. So we have capillary loops, we have terminal loops, we have lymphatic vessels, we have arteriovenous anastomosis. But as we know that there is only one entry and one exit to go, it lacks the collateral circulation. There is, if one vessel is damaged, it is not something that there is some another way through which the circulation or the supply or blood supply or the demand is being compensated. So that's not possible in the pulpal vasculature within the pulp. So how do we regulate this pulpal blood flow? So pulpal blood flow is regulated through various aspects. So most of the times, as we have in the normal inflammation, the first most response that we have, that is increased capillary pressure, increased hydrostatic pressure, that leads to vasodilation, right? So most of the components leads to vasodilation. However, we have some components like sympathetic fibers and the trigeminal efferent fibers, which may have negative impact and which may have a positive impact and cause the vasoconstriction. So rather than producing vasoconstrictions, we have the more factors leading to more vasodilation, and which may in turn sometimes prove to be fatal because they are not able to compensate and filter and do the capillary reabsorption, right? That leads to the pressure within the pulp and may lead to pulpal necrosis, right? So how the blood flow occurs during the inflammation? So whenever there is a inflammation, first thing, as we know, vasodilation occurs. As vasodilation occurs, what the other thing comes along with the vasodilation is increased vessel permeability, as it happens in normal inflammatory process, right? So once vasodilation occurs, that would be increased blood capillary pressure. As there is increased blood capillary pressure, also there would be increased capillary filtration because of increased vascular permeability, right? Now all this together will lead to increased fluid volume within the pulp. So this increased fluid volume within the pulp will further increase the tissue pressure, and this increase in tissue pressure will lead to compression of the venules. This compression of the venules will again increase the venous pressure, and there would be again the increased blood capillary pressure, and the vicious cycle of the inflammation would go on and on, right? But this can be stopped, or this can be stopped. How we can stop that? There are two ways to it. The increased tissue pressure will increase the fluid volume. The increased fluid volume will increase the capillary filtration, and this reverse cycle goes on. The other way we have is that there would be due to this increased tissue pressure, there would be absorption of the excess amount of fluid into the non-inflamed area. Another thing is we have the lymphatics that pass by along with the blood vessels to absorb the interstitial fluid, and the lymphatics would be drained through this lymphatics, and the blood volume would be returned to its normal state and it can be stopped. However, in cases of extreme inflamed condition, if this does not occur, then this vicious cycle will go on and it will act as a self-strangulation, right? So what happens is we are by our own inflammation only, we are self-strangulating. There is of the pulpal blood flow, and which is increasing the pressure again and again, and it is finally leading to pulpal necrosis, right? So it is most important to us that when at the initial stage where we have the facility of capillary filtration and we have the facility of absorption and all, we must take some actions to preserve the pulp and prevent the necrosis, right? So how this occurs, that whenever there is a response within the pulp, right? So there is a localization of the pulpal inflammation and microcirculation. So how this occurs is that we have a robust physiological feedback local control mechanism which opens the shunt vessels. And what happens, this is that there is an increased tissue pressure within the pulp and there is an inflammation starts. As this occurs, there would be the opening of the shunt of the adjacent lymphatics. So all of the interstitial fluid would be reabsorbed into the adjacent through the lymph flow and through the non-inflamed areas. So this occurs, and thus the inflammation stays only at the local site and is not extending ahead and ahead. And overall, even if it is extending, it is a very slow process. So it has been studied in the various studies, and they have proved that the pulp interstitial fluid pressure remains normal in the adjacent pulp tissue, this 1 to 2 mm distant to the inflamed area. So if the inflammation is in the pulp chamber, then it will rely in the chamber for up to 1 to 2 mm. Distant areas more than 2 mm, the pulp flow and the inflammation was normal or there was a mild inflammation. So this is the inflamed area and other part is mildly inflamed or non-inflamed, right? So if we remove the irritant at this point of time, then we have a chance that the pulp may return to the normal state. So this is the initial stage where we can say this is the reversible stage of the pulpal inflammation, where we may get minimum amounts of signs and symptoms through pain, which we will discuss further in this lecture. And this forms the basis that as the pulp is responding in a very compartmentalized manner, systematic 1 mm, 2 mm, then next 1 mm, 2 mm, and it is not just spreading massively at a single go. So this local inflammation of the pulp and control and regulation by the microcirculation within the pulp through is what forms the basis of the vital pulp therapy, pulp repair and pulp regeneration. That we can see we have deep caries approaching the pulp, and if we have iatrogenic pulpal exposure, so in that cases we can remove the irritant, or we can do the SWEG pulpotomy, just of the removing that much amount of 1 to 2 mm of the pulp chamber, which is or the carious portion of the pulp, and we can just put a medicament and we can go for the healing. In this way, this is the reason, the localization of the pulpal inflammation is the reason for the vital pulp therapy, right? So we must know it, that how we can correlate it clinically. Next is that once we have learned about the vascular component, now then we will come upon how neural component within the pulp contribute towards the inflammation and how they are responsible, and they mingle with the vascular component in producing the signs and symptoms, that is pain. So the nerve supply to the tissues or the dental branches, we have it through the trigeminal nerve. That is, by the maxillary branch, we have the superior dental plexus through superior alveolar nerve that divides from posterior, middle, and anterior. And we have it through the inferior alveolar nerve, and this and the mental nerve, which forms the dental branches and inferior dental plexus, which finally enters from the apical foramen. And in the core region, we have the C fibers, which are unmyelinated, and we have the A delta and A beta fibers, which are the myelinated nerve fibers, right? So, and they are present in the pulp horn, in the free nerve endings, and the free odontoblastic process. They end up into this odontoblastic process. So these are the first most fibers. They are the nociceptor fibers, right? What do we mean by nociceptor fibers? That they can induce pain only, right? So they will induce pain, and to the as a response to the stimuli, right? And so they are the first most A delta and A beta fibers are the first most fibers. They would be receiving the sensory signals or through the stimulus whenever the odontoplastic process are affected. So the sensory fibers, as we know, that A delta fibers, they are the fast conducting, most conducting fibers, and they have the higher amount of velocity, and they respond to pain, temperature, and touch, function as a pain, temperature, and touch, and they are activated by air blast, heat, cold, drilling, probing, or hypoosmotic procedures. A beta fibers are also there. So they respond to pressure and touch, and they are activated by vibration. We must remember that which fibers are activated by what, to understand that how the pain signalings are going. And other fibers, we know that they are A delta fibers. They are slow fibers, and they are activated by inflammatory mediators. However, all these fibers produce a pain that is fast, sharp, short lasting. It is non-lingering, and it is well localized, right? But we have, these are the myelinated fast conducting fibers. We have another non-myelinated C fibers. They have they are activated by inflammatory mediators. They are intense, by intense heat and cold, or slow, and they are characterized by slow, dull, aching, pain, throbbing, long lasting, lingering, and they are spontaneous, right? And so A delta fibers are basically oxygen sensitive. So in cases of hypoxia, they would be the first ones to get destroyed and to get dead. So it is and they have a low threshold, right? On other hand, C fibers, they have high threshold, and they are less sensitive to oxygen, presence of oxygen. So they are the ones that even sometimes what happens that pulp chamber, we may not feel pain, but during biomechanical preparation, when we enter the canal, these fibers are responsive and may induce pain when we are filing through the procedure or removing the pulp in between. So this forms the basis that as inflammation progresses, the fibers which will be active during this point of time would be C fibers in the intense inflammation case. Right. So next we have are the neurogenic mediators. So these neurogenic mediators, they are induced and activated through the sensory nerve terminals by the vascular component. So right, vascular component leads to inflammation. Inflammation activates, sensitizes the nerve endings. This nerve endings will lead to release of this neuropeptides, which we are called, and these neuropeptides leads to certain functions like vasodilation, vasoconstriction, and or they may lose substance P and inhibit the pain or something. And so they play an important role in increasing the inflammation and passing the nociceptor impulses to further pathways of pain through spinal cord and thalamus, right? So this forms the basis of neurogenic inflammation. So neuropeptides forms the basis of neurogenic inflammation. Okay. So what is this neurogenic inflammation basically? that we have both myelinated and unmyelinated sensory axons stored within the that store this pro-inflammatory neuropeptides in their terminals. So whenever there is pulpal inflammation, this sensory axons stimulate this neuropeptides. This neuropeptides will be released to the this activation of this nociceptors. So ideally, what they are supposed to do is they are supposed to go through a normal orthodromic pathway. That is, they are supposed to go conduct the impulses and reach through the trigeminal nuclei and the higher brain senses to evoke the pain sensation, right? But what happens is sometimes that they go for an endodromic pathway, and to the site at which the injury has occurred or the site at which the cells are present, and they will release the calcitonin gene related peptide and substance P at the vasculature aspect point only. So rather than going, as we can see in the video, that it is the impulses are generated and they must go to the central nervous system. However, these impulses, rather than going to the central nervous system, they go to the site of the blood vessels and site of the cells and release this neuropeptides at that site and increase the inflammation. So the inflammation which is produced due to the nociceptor impulses activation is known as neurogenic inflammation, right? Now, once this neurogenic inflammation occurs, this leads to increase in the pulpal inflammation. Now, this comes the neural aspects, and we must now go that how it induces to the pain eventually through the pulp. So, the sequences of events that leads to this pulpal inflammation pain are: we have a caries, we have a bacterial exposure that will lead to the release of toxins like liposaccharides and the other endotoxins and exotoxins by the bacteria, the debris and everything. So this will sensitize the free nerve endings at one end, and then second end it will activate the immune system, right? So this sensitive free nerve endings and the immune systems are activated. This activated sensitive free nerve endings will release the neuropeptides, calcitonin gene related peptide and substance P, and on the other aspects it will innervate go and send the impulses to the trigeminal nuclei. This leads to the vasodilation of the blood vessels by the neuropeptides, and it will induce neurogenic inflammation, okay, as we have discussed before. On other hand, the innate system, immune system which is activated, will further release the inflammatory mediators by arachidonic acid pathways, and that is COX-1 and COX-2, and which increase in prostaglandins, prostacyclins, cytocrines, bradykinin, and all those functions. And this inflammatory mediators will lead, number one, to vasodilation, as we know, and vasoconstrictions by prostacyclin, and also all these three aspects will lead to symptoms of induced pain. So this is the way that there is an activation of inflammation occurs. Inflammation activates the free nerve endings, and the whole cycle goes on to induce the pain. So as this is the same aspect is being depicted in the diagram. This diagram is given in Ingle. So this is the point where the initial inflammation has occurred, and this initial inflammation is the point where we are supposed to, this is the first order neuron pathway through which the pain is being transferred to the trigeminal nuclei and leading to the symptoms. Now, if we at this point of time we do not control the pain, then what occurs that repeated stimulation occurs, repeated irritation occurs, And this repeated irritation will lead to some of the phenotypic changes, the physical or the morphological changes within the free nerve endings itself. So this free nerve changes which leads to the free nerve endings, it's known as peripheral sensitization. So just like you tease a person for 1 time, 2 times, 3 times, the person will ignore kind of thing. But if you provoke that person repeatedly for 10 to 15 times or 50 times, eventually the person gets sensitive to that matter. If you tease a fat person, you are fat, you are fat, you are fat, and then eventually they will feel that okay, we are fat. And so even if the 51 time you tell that person you are fat, rather they would be taking it lightly, they would respond to you in a very strong way, in a very headstrong way, in a very anger. So this same thing happens with our peripheral sensitization. So how this occurs is, number one, by morphological changes, that is, it will lead by sprouting of the free nerve endings. As we can see, the dendritic free nerve endings will be sprouting, then the extensions will be increasing. The next thing that could happen to them is by increasing the amount of neuropeptide release, right? Previously, 5 neuropeptides were released, there would be upregulation, more number of neuropeptides will be releasing, which is increasing the neurogenic inflammation. The third thing that may happen would be demyelination of the nerve fibers or a part of a nerve fibers, which will increase its sensitivity. And sometimes we have the awakening of the silent nociceptors. So what is this awakening of the silent nociceptors? As we talked is that we talked about A delta slow fibers. So this A delta slow fibers are activated by the inflammatory mediators. So previously they were silent, but now they are also getting sensitized and they are increasing the amount of pain. So this is what is peripheral sensitization leading to the symptoms of pulpitis. So how this is represented clinically is by allodynia, that is decreasing the firing thresholds of for detecting the painful stimuli. So there would be pain, tenderness on percussion, on chewing and diagnostic percussion. So the most common complaint the patient will come that, oh, I cannot eat through this side, as soon as I chew I have a pain. So we must know that it is a kind of it's a allodynia. The next thing that would be an hyperalgesia, that is increase the enhanced painful sensation to the previously non-painful sensation. So this is the exaggerated response. This is to the pulse sensibility testing is known as a hyperalgesia. Another thing would be a spontaneous firing of the nociceptor that would be contributed. So this is the spontaneous pain that is being produced. So these are the 3 clinical symptoms that we can get to know that it is a stage where peripheral sensitization has been occurred, and this most commonly gives us an idea that pulp or the pulpal inflammation is going towards the irreversible state, right? So how we will go, that patient is not able to chew from that side. Secondly, it has an exaggerated response to the sensibility testing, and or the patient complains of a spontaneous pain. Now, even if we do not take any actions during this point of time, now this will respond to the stronger painful sensation goes towards the central sensitization, right? So what is this state of central sensitization? Now the second order or the third order neurons will come into the picture. So till peripheral sensitization, what we know is a patient is having pain, but patient can localize the pain. Now what happens is there is a prolonged bombardment of the nociceptive signals. The irritation is going on to the C fibers. So what will C fibers do? It will go and report to the thalamus, the medullary dorsal horn in the spinal cord, which is the caudal portion. So it will tell that it is doing this, and it will release the glutamate and substance P there. So this release will increase the upregulation of the central receptors, And this central receptors within this medullary dorsal hall will upregulate and send the sensations through the spinothalamic tract, which is responsible for producing pain and pain perception to the thalamus and the cerebral cortex, that is the third order neuron response, right? So now this all aspects will lower the threshold of the mechanoceptors that are present within the thalamus, and this low threshold mechanoreceptors which are present within the thalamus and the local circuit neurons and the wider dynamic neurons which are present within the spinal cord will lead to a type of pain sensation. How they will lead to the pain sensation is this local circuit neurons, they will decrease the pain threshold, right? Next, the wider dynamic range neurons, they are specifically responsible for signaling the severity and the location of pain. That okay, it is mild, moderate, it is very much like, you know, on VAS scale as we measure. So these are responsible for that. So now, as this dynamic neurons, what they supply to the superficial part, and they stimulate the deep part. Whenever they supply to the superficial part, the pain is usually localized, and as they receive input and repeated input, now the pain affects the deeper areas of the tooth, and thus it will lead to the also affect the superficial plus the deeper areas along with that. So this central sensitization which will go to the thalamus will increase the amount of mechanical allodynia, will lead to, there was the lower threshold was already there, it will lower the threshold more than the previous one, so that will lead to secondary hyperalgesia and it will lead to referred pain. So previously we were able to know that okay, it is 3/6, I am having pain in 3/6, it's a spontaneous pain in 3/6, it is a night pain in 3/6, but still eventually what happens is I am having pain in lower region. Which region? I don't understand, right? So that is the state where the pain has reached its peak to the severe through the central sensitization part. So what affects the referred pain is the central sensitization through the wider dynamic neurons and the local circuit neurons that we need to understand. And this means that it has increased, this is the state of the severe inflammation that is being present in the pulp leading to the pain. If we do not take actions at this point of time also, there are high chances that we may, this condition will lead to the pulpal necrosis, right? So depending upon the death, we have the type of pulpal injury that is the least damaging type, like shallow cavity preparation, shallow scaling and all. And type 2, we have a most extensive dental injuries. The injury has occurred, there is a local vascular response, but pulp has capacity to repair itself and form a reparative dentin. So these are the stages, first type 1 and 2. This indicates the deep dentinal, like for type 2, we have deep dentinal cavities, small pulpal exposures, heat stimulation and all. So type 1 and type 2 are the stages, as we have known, are considered as a reversible stage of pulpal damage. And type 3, where enough pulpal damage has occurred and we have lost the, now local repair is not possible. So this is the irreversible stage. So type 3 injury is and type 4 injury is an irreversible stage. In type 4, even the periodontal tissues are involved and periradicular tissues are also involved, and that is other tissues in addition to the dentin and pulp. So these are the irreversible stage of the pulpitis, where we have to go for root canal treatment. However, in cases of type 1 and 2, we may consider for the restorations or a vital pulp therapy. So clear about this. Next we have is based upon this, we have the etiology which causes the pulpitis, which may be physical, chemical or bacterial. So physical, we have the mechanical or the thermal, and that is by mechanical by trauma, by crack, by pathologic wear like attrition or abrasion, which increases or exposes the dentin and leads to the barometric changes, that is barodontalgia, which reverses the pressure within the pulp. Thermal, we have the cavity preparation heat, exothermic heat, or the setting of the cement and all, and the bacterial toxins. So these are the etiology which causes the pulpal inflammation. Based on the different types, the gradient response of pulp we see. The types are reversible pulpitis, irreversible pulpitis. It could be symptomatic or asymptomatic. Previously, they called it an acute and chronic. But acute and chronic are basically the terminologies are denoted with the duration of time, whether they are occurring with a shorter duration, 24 hours to 7 days or something, or they are occurring more than 15 days or something. So, considering a bit of controversial of whether the patients were having symptoms, whether they are not having symptoms and type, so better terminology has come now is a symptomatic and asymptomatic. Another one is chronic hyperplastic pulpitis. So first most thing that we have is the dentine hypersensitivity. So this dentinal hypersensitivity is the most accepted theory that we have is the hydrodynamic theory, which responds to the hydrodynamic response to the strong capillary force within the fine dentinal tubules that occurs leads to the rapid fluid movement. This rapid fluid movement will activate the A delta fibers and lead to a sensitivity kind of pain. So whenever we blow a strong air, or dehydration or desiccation that we call, that will activate the A delta fibers and induce a short momentary kind of a pain that will lead to a sensitivity. So this is the stage where it's affecting the dentinal process, right? However, the inflammation has not yet occurred. The next stage is the irreversible stage, where pulp is capable of returning to the uninflamed state. So what kind of pain we have? Short and sharp pain, specific to a stimulus, cold or sweet food, and it is instantly relieved on the removal of stimulus, and pain occurs with extreme temperature changes, and that is more often by a cold. That is, we need to remember in this case. And what happens with the pulp sensitivity test? This is the one of the most clinical aspect we need to remember. Pain will occur, but it would be very sharp and for a very shorter duration of time. It would not be lasting for much lingering period of time. And radiographically, the other PDL and other features would be absolutely normal, right? Next, we have irreversible pulpitis, where we cannot return to the healing. We have a short pain, but for a longer period of time. We can have an occasional pain. We can have a sensitive pain. Even if the mild temperature changes are there, even the tap water can cause pain. So this is the clinical scenario that we can ask to the patient that is it the normal water also causes pain, or the pain occurs when you go for an extreme cold consumption of water or extreme cold food, right? So it is sharp, severe, or may become dull, and it lingers for a longer period of time. That is more than 5 minutes. They say through the literature, and we may find that the caries are extensive and their breakdown is more in such cases. In thermal testing, we had a sharp, painful pain, but it lingers for a longer period of time. So, and may involve PDL involvement would be there. There would be widening of PDL involvement, or sometimes apical periodontitis may be present in such cases. Chronic hyperplastic pulpitis is a condition which occurs in young people, and which occurs due to development of the granulation tissues covered at the time with the epithelium, and results in a long-standing low-grade irritation which occurs. So patient may be asymptomatic, and most commonly they have a pain when they are masticating because of the pressure of the opposing cusp that is inducing on the pulp polyp which is present, and they have an extensive caries. So This is generally seen in children or young adults, where we see a polypoid tissue clinically, as seen here, with fleshy red pulpal mass spills of the pulp chamber or cavity and extends beyond the confines of the teeth. So typically, what diagnostic test we can use for this is, we have a neural sensibility test, will be based upon the response of A delta and C fibers, and the pulp vascularity test, which will see the actual pulpal blood flow. So we have pulse oximetry, laser Doppler flowmetry, and other kind of tests as the recent technologies we have. We are not going in detail right now for this, but how these tests are useful to us. Basically, thermal tests are the pain reactions to the extreme temperature differences that we must remember. This is the basis of the thermal test. So we may go for a cold test, which is considered as an ideal test for pulp vitality, or we can go for the heat test, and or the pencil of ice or the ice under rubber dam isolation. So out of the cold test, the most reliable test which is considered is the cold CO2 snow. That is the end of frost that we have, is one of the tests which can be used. Next, we have a heat test to see in cases of the irreversible pulpitis. So how we can diagnose? If through the thermal test, basically. So if the pulp is doomed normal, there is response to a stimulus provided by a sensibility test, and this response is not exaggerated, it does not linger or something, it is a healthy pulp. If we have an exaggerated response that is producing pain, or that produces pain, right, we must know that this is pulpitis, right? So if this pain is mild and lasts for a shorter duration, we must consider irreversible pulpitis. If it is severe and it lingers for a longer period of time, it is irreversible pulpitis. And if there is no response to the thermal test compared to the adjacent tooth, then it is definitely a pulpal necrosis, or it is a pulpless teeth, or it is a previously teethed tooth that we can come up to this. Next is we have electrical pulp test, which is the basis of electrical pulp test. We must know that it is due to the ionic movement. So electrical conductivity that causes the ionic imbalance crosses the neural membrane, and this induces an action potential and increases the rapid saltatory conduction of the at the Ranvier node in the myelinated nerves. So additional to this neural transmission, other things like electric current cannot be conducted to an ion-free solution. For example, in cases of distilled water, we might have a false response. So what response we have, how we must diagnose based upon the electrical pulpal test response. So we have a normal response, that is adjacent tooth, we record the basis at which the response was occurred, that we take as a reference, and then we take the tooth which we are diagnosing. If we have same response as to the control tooth, we consider it a normal tooth. If we have early response, then it is reversible pulpitis. If we have a delayed response, then we have a irreversible pulpitis. And if we have no response, then it is a pulpal necrosis. However, in this case, we would always sometimes have errors with EPT. So we may have a false positive response. What is false positive response? That even if the pulp has undergone for a necrosis, we will get a response that it is a inflamed tissue. For example, if we have a 3 or 4 pulp horns, and one pulp horn is affected but the other is not affected, so we may get a response. So it is a partial necrosis of one part of a pulp, but other pulp is having inflammation, but we are still getting a response where the partial pulp necrosis has started, but still we are in the feeling that the pulp is at the stage of pulpitis. And if the isolation is not proper, we have a metal restorations. Sometimes you also get false negative response. How that even there is a pulpitis is present, we think that pulp has undergone necrosis. So which are the specific cases we have? We have the immature pulp, that is plexus of Brasco, in the children is not developed. The nerve endings are not developed effectively to stimulate so strongly to the electric pulp test. In the obliterated calcific teeth root canals, in cases where we have a recent trauma where there is a neural injury has occurred and shock, due to the brief period of shock, we do not have a response even if the pulpal inflammation is present. So most common amount of time, we in the routine examination, we must always go for cold test by carbon dioxide and combination of electric pulp test. But in cases of pulpitis, cold test is considered to be more reliable than EPT, and in cases of necrotic pulp, we must go for both. In cases of pulpal calcifications, we may go for electrical pulp test, which is more reliable than the cold test. Right. So based upon this clinical scenario, we must opt for the types of diagnosis. In cases of crown and bridges, this is the most common. Clinically, we may face a problem that if there is a crown and bridge, which test should I do, which test should I not do? So cold test with the help of carbon dioxide endofrost is considered to be the most reliable test in crowns and bridges. So in this way, we can take help of the diagnostic pulpal tests to for the diagnosis. Clinically, how do we approach? By history, by clinical examination, responses to pulp diagnostic test, followed by radiographic examination. So if a patient is coming to our clinic with a history of dental pain, patient may have a provoked occasional sensitivity to heat, cold, or extremely cold, or like most commonly to sweet and cold. Or patient may come with a spontaneous night lingering pain, mild or to the mild temperature changes. Or patient may have no response, or patient does not have any pain at present, but patient had pain previously a few months before. Next, we will go for clinical examination. In cases of occasional pain, we have a dental caries, or we may find deep dental caries, or we may find a restoration. We may find some broken restoration, a crack on biting pressure or something. So we must rule out all this, the signs of cracked tooth syndrome in cases. Next, we would come upon the pulp vitality test, which will go for thermal test and electrical pulp test. In thermal test, we will get a pain which is sharp duration, but cold test, but we will not have any response to heat test. We must remember, right? So provoked occasional sensitivity, the dental caries just extending up to the dentine, 1/3 of dentine or enamel. Cold test, we have response for a shorter duration, not much response to heat test. This gives us an idea that okay, we are coming up to a diagnosis of a reversible pulpitis, right? But in cases of we are having spontaneous pain, night pain, lingering pain, and either or and we are having deep dentinal caries, and we have hot and cold test, both are responsive to the and positive, and the pain is lasting for longer. So this gives us an idea by this point of time of pulpal thermal test, the DS, we are approaching a patient which is having irreversible pulpitis, or it may have no response. And electrical pulp test, if we have early response, we are definitely having coming based upon the clinical aspects, we are knowing that it is a irreversible pulpitis. And if it is having delayed response on electrical pulp test, we are coming to the based on clinical examination, the diagnosis is irreversible pulpitis. And if it is having no response, then this gives us a diagnosis that the pulp has undergone for pulpal necrosis. Next, we will go for radiographic examination. As we have seen that it would be extending till dentine, or we have normal PDL space and everything, then our diagnosis is reversible pulpitis. If we have signs of apical periodontitis sometimes and all, and based upon the clinical and other aspects, it is definitely irreversible pulpitis. And if there is no response to EPT, no response to thermal test, and we may find some periapical abscess, apical periodontitis and all, and periradicular findings are present basically, then it's definitely telling us that it is pulpal necrosis, right? So this is the approach how we can go clinically correlate the basis and come up to a diagnosis. So as per American Association of Endodontic consensus, we have normal pulp, which is having a symptom free. We have a reversible pulpitis based upon the finding that gives that the pulp may resolve and return to normal. We have symptomatic irreversible pulpitis, which has clinical signs and symptoms, and that is having lingering pain, spontaneous pain, referred pain. We have an asymptomatic irreversible pulpitis, as we know that is same, and we have like no clinical symptoms, but we have it may be produced when we are excavating the caries or when there is a trauma. And we have a pulpal necrosis, and clinically it is ideally pulpal necrosis. Most of the times when we go for our examination, there is a histological aspect. So we can have that clinically if they are, as per this consensus, the definition says that if they are usually non-responsive to the pulp testing, then we can call as pulpal necrosis. So based upon our clinical finding, we define pulpal necrosis, which is non-responsive to the pulpal testing. So this is one of the commonest viva questions that are being asked usually during our practical examinations by the examiner, that pulpal necrosis is a histological terminology. How do you, can you tell that clinically based on this finding that it is pulpal necrosis? So we have this definition to give us our defense answer. So sometimes we have pulpitis, but it is symptom free. We do not have any pain. So we see varied patients. Some patients are having extreme pain. The others are not having pain and it's almost gone. So this is due to some of the inhibitory neuromediators such as somatostatins, endogenous opioids, which activate the GABA receptors, and these GABA receptors which are responsible for the inhibition of the nociceptor A-beta activities, and this reduces the pain and it inhibits the pain pathways and leads to gives us the symptoms of silent pulpitis. Next sometimes we have a heavy occlusal forces. These heavy occlusal forces leads to alteration within the blood flow, and they are responsible for completely blocking the arterioles that are passing through the apical foramen, and may lead to the increase in intratubular and intrapulpal fluid and amount of fluid and interrupt the movement and lead to the pulpitis and eventually lead to pulpal necrosis. So the sequelae we have normal nauseous stimuli causing inflammation leads to reversible pulpitis. If we do not treat, it leads to the irreversible state, and then it may, if it's a young tooth, it may go for chronic hyperplastic pulpitis if it is or symptomatic irreversible pulpitis, or if sometimes asymptomatic irreversible pulpitis, that is the silent pulpitis we can, and eventually the pulpal necrosis. The another most specific condition that we come across is hot tooth. So what is this hot tooth condition? Is a condition when the tooth is difficult to anesthetize. This forms the basis that when we have sometimes the patient comes that we are anesthetizing the patient, but still the patient is having pain. So what forms the basis of this hot tooth pain? So we have the sodium channels, 9 to 11 voltage gated sodium channels present within the C fibers. Of this, 8, 9 and 10, they are the channels which are considered tetrodotoxin resistant channels. So this last 3 channels, so whenever we give anesthesia, all these channels are getting sensitive to the local anesthesia, and they will be having the anesthetic effect. However, when there is an increased amount of peripheral and central sensitization and hyperalgesia state, the primary and secondary hyperalgesia has been known in cases of peripheral sensitization, the threshold is very low. So what happens that this last 3 voltage gated channels, that is 8, 9 and 10, they are becoming resistant to the tetrodotoxin, which is one of the component of the lignocaine anesthesia. And initially they were sensitive to this component, but now due to the hyperalgesia, they are not they are resistant to this component. So these channels will not be anesthetized. So due to this non-anesthetized sensitive channels, they would be responding, and they're more 5 times more resistance, you know, and they give a rebound response to the inflammation and inflammatory effect, and causing the more amount of inflammatory hyperalgesia. So because they are not getting anesthetized, due to this point of time, even if we give anesthesia, the patient feels the pain and we are not able to treat that tooth. So we may get confused that we haven't given the inferior ivory or a nerve block properly. We have given everything properly, but still the patient is having pain. So in such cases, what we may do, we may have to wait for a longer period of time to get the effect of anesthesia, or we may ask the patient to come taking a previous analgesic medication, which will centrally inhibit the pathways of pain and will be helpful for us to treat the patient at that point of time. So these are some of the conditions that we have, that we know the pulp. We know the pulp vasculature. It is having the graded compartmentalized response, which forms the basis of vital pulp therapy, in which it is at the reversible state. Eventually, if we are not treating that teeth, it is going into the irreversible state, and this way we have, and accordingly it is activating the fibers, that is initially the A delta fibers are activated. As soon as it is increasing the strangulation, increasing the inflammation, there is a hypoxia because of the initiation of the pulpal necrosis. So or ischemia within the blood vessels, the A delta fibers are not getting they are getting no, they're degenerated. So we have the response of C fibers, which is producing the increased amount of pain, and then we have a state of hot tooth. So we must go for a clinical signs, symptoms, history, and reach to a proper diagnosis in a way and plan our treatment. So hope this lecture has helped you out to come up to a and cleared your aspects regarding the diagnosis, how we need to make based on the history, based on the diagnostic tools or the sensibility tests that we have, and come up to a proper diagnosis and a proper treatment planning at the end to get a successful treatment outcome. These are my references, that is Cohen, Engel. Even we can read Grossman for the UG students. It is given good in the diagnostic chapter number 3 or 4, and this becomes the rationale of the endodontic treatment, that is how the inflammation and the neural responses are there. It is given in the rationale of endodontic treatment. So hope this lecture has been useful to you, and now it's clear for you to go for a proper diagnosis and treatment planning in cases of pulpitis. Thank you.